Well, good morning.
Morning.
I'm Eileen McEnany, President of the Mass Taxpayers Foundation and co-founder of the Massachusetts Employers Health Coalition. And it's my pleasure and my honor to welcome you here today. Judging by the crowd this morning and the interest that I hear when I'm out and about and the media coverage that we've received to date, I really think we're on to something. There's certainly a time and a place for legislative action, and as a public policy professional for a long time, I certainly know that, but not all that's broken in our healthcare system can be fixed legislatively. Sometimes it requires private sector action and intervention. And I firmly believe, and I know my dear friend Rick Lord, who is the president and CEO of AIM and the co-founder of the coalition, I know he firmly believes too, that the best way to effectuate change in the healthcare marketplace, particularly for the commercially insured, is to help educate consumers and to better inform them on the consequences of their choices. I say this often, but I am a firm believer that I think people will make rational choices if given full information about their options. And really, that's what this coalition is all about. It's about aligning incentives and educating people about the consequences of their choices. It's about compiling, summarizing, and disseminating cost and quality information in a format that is usable by all the employers that we collectively represent, and it's quite a few, and their employees to make these informed choices. It's about using our collective purchasing power to affect change. If we connect the dots for patients as to why choosing an emergency department may not make sense for them in some instances, both personally and for the system at large, and we inform them about lower cost, effective alternatives, I'm confident that we'll change their behavior and take unnecessary cost out of the system. And while we're still at the initial stages of this coalition's efforts, there's already, I think, a discernible difference between past attempts to engage employers in this time around. And I think the difference is the support of the Health Policy Commission, both in terms of the data that they can provide and the staff support they've been able to lend to this effort. In addition to developing materials and the website, they've kept us laser focused on moving the coalition forward. So please join me in giving both David Seltz and David Auerbach, Colleen, Aisha, and the whole Health Policy Commission team a big round of applause. I also want to acknowledge Representative Jeff Roy, the Vice Chair of Healthcare Financing, who's joined us, and the numerous staff. And the numerous staff, legislative staff who's here, if you could just stand and be recognized. We have a wonderful program in store for you. I look forward to moving ahead collectively and proactively to take unnecessary costs out of the healthcare system in a way that translates into lower premium costs for all of you. And that's why I think it is so important, and what's different about this effort, that it is employer-led. So with that, I'm going to turn it over to David Seltz. Thank you.
Thank you, Eileen, and good morning, everyone. Thank you for being here. We know this is a really busy time of year and that there are other options you may have had this morning, but you chose to be here today, and that is truly exciting, and I think a reflection of how promising this new effort is, and dare I say, ambitious. And so I do, at the beginning here, want to thank Rick and Eileen in particular as the co-chairs of this new Massachusetts Employer Health Coalition for their leadership and vision in really making this effort happen. You have been truly critical in mobilizing employers to this cause, and I really applaud your vision that employers can and should play an active role in promoting our shared goals of a more affordable, innovative, and effective healthcare system here in Massachusetts. On the screen, you can see all of the members of the coalition, many different employer organizations representing thousands of small and large employers across Massachusetts. And also want to recognize the strategic partners who are listed here at the bottom of the page and who are in the room here today with us. So thank you. I saw Steve Walsh, Dr. Weiner from MASEP, Laura Pellegrini from MAP, and Erica Wilkinson from Blue Cross Blue Shield, and we're going to hear someone else from Blue Cross Blue Shield a little bit later today. The Health Policy Commission is also a strategic partner, and we're proud and really excited to assist this coalition and this effort moving forward. We've made some really important progress in the last 6 years since the passage of our landmark healthcare cost containment law. In the most recent year, total healthcare expenditure growth in Massachusetts was 1.6%, a full 2 percentage points below the 3.6% goal set in law. But not everyone is benefiting from this lower cost growth. And in that same time period, we saw that premiums, especially for smaller employers, were growing at a much faster rate. Out-of-pocket spending in the form of copays and deductibles for our residents was growing at a much faster rate. And for some lower income employees of Massachusetts, we calculate that a full 30% of their income is being diverted to the cost of healthcare. This is not the time to declare mission accomplished here in Massachusetts. And we need to set ambitious goals for ourselves if we're going to be able to continue to meet the benchmark moving forward and reduce unnecessary spending. And I'm sure Rick will talk about this later, but a recent AIM survey said that healthcare costs continue to be the #1 concern for Massachusetts employers. We're proud to support this effort because this is an aligned strategic goal with the Health Policy Commission. So on this slide, earlier this year, we released a study that looked at a number of different scenarios about where we could save money in the healthcare system in Massachusetts. We had 7 different scenarios that we modeled out, totaling about $5 billion in savings over the next 5 years. And while reducing avoidable emergency department use is not the biggest category that we identified here, the employer coalition members really identified this as the one in which they wanted to focus for a few different reasons. One is I think employers can play a more direct role on this particular challenge area in influencing behavior and educating employees about the right settings of care. Second, I think it's fair to say that we had universal agreement among our stakeholders that reducing avoidable emergency department use, done right, can lower healthcare spending, increase quality and access for our residents, and potentially reduce ED crowding in our emergency departments, and let our highly skilled, excellent emergency physicians have the time and capabilities to treat all of us when we do need that level of high quality emergency care. And third, as we'll hear from today, in this particular area, we do have some models to learn from. And so later today, as a big part of this presentation and our keynote, we're going to hear from St. Louis and where they have taken this particular challenge area on. And so part of the goal for today is to learn from their efforts and help them inform the work of the coalition moving forward. Our other goals for today is to build awareness and engagement with this coalition. There are so many people in this room. We want you to be connected to this coalition and the work of the coalition, to collaborate today on identifying solutions, and finally to leave here today with a dedication to take action. Because this is not just a coalition that is around presenting data, having a nice hot breakfast, and walking out the door and not doing anything. This is a call to action, and we want everyone in this room to be a part of this effort in 2019. So one of the key ways that the Health Policy Commission is supporting the work of this coalition is through our data assets. And so for the rest of my presentation, I want to talk a little bit about the data and what we know about emergency department utilization, avoidable emergency department utilization, and some of the data assets that we have to be able to measure and track our progress in this. So this first slide just looks at emergency department utilization overall. And you can see that Massachusetts in the orange line here compared to the United States in the blue line, that we have a higher utilization of the emergency department per 1,000 residents than the United States average. If you can look in this last year of data that we have, there's actually a slight divergence between Massachusetts and the United States, where we slightly ticked up and the United States slightly ticked down. On the right-hand side of the slide, you can see the breakdown of those emergency department visits into the major categories, which is to say that 30% of these emergency department visits are commercially insured. A big focus, obviously, for this coalition. This next slide is a very wonky Health Policy Commission data slide, fully admit it. But I did want to just highlight the fact that in order to track and understand emergency department utilization, we have to use a lot of different data sources in order to understand this. So in this presentation and through our work, we mainly think about these three different data sources. One is an annual discharge database that's collected by the Center for Health Information Analysis. Has great information on utilization and diagnostic codes of patients who arrive in the emergency department. Not so much great information on the actual prices paid for those services. In the middle, we have our all-payer claims database, which provides a great level of detail, including on the actual amounts paid and what patients paid out of pocket. But we only really have that for the top 3 commercial payers, and the data can be quite time delayed. And then finally, we have survey data. So every 2 years, the Center for Health Information and Analysis fields a resident survey asking a lot of different questions of Massachusetts residents, including about their use of the emergency department. And today's presentation, we have some new analyses based on this survey data that I'm going to show you in just a minute. But I did want to just emphasize again that there is a challenge here in being able to categorize and track avoidable emergency department use. And there's no perfect way to do this. In a lot of our work at the Health Policy Commission, we use what is known as the Billings algorithm. The main point that you need to know is that this is a way to retrospectively look at data and be able to classify emergency department visits as either non-emergent, which means that that patient likely did not need immediate care and was at the emergency department, or what we call emergent but primary care treatable. And these are visits, when you look at the data, that indicate that yes, some care was needed, but that care could have been safely and effectively provided in a lower cost primary care setting or urgent care setting. So when we look at the data, we do break things down in these different ways. It's important to recognize how we interpret and look at this data depending on these different categories. And I would say, in each of these cases, we are looking at this retrospectively. And that is a different perspective than what an emergency physician who's looking at a patient in front of them may look and know. So we recognize that this is a challenge from the coalition standpoint, and that's why we're going to be establishing a data and measurement work group in 2019. And we do think Massachusetts can be a national leader in terms of finding the best and most effective way to track our progress on emergency department utilization. So with all those disclaimers, I do want to show you some data about what we do know from all of those different data sources. So the first slide here is looking at that survey data. So the new thing that we've done here today is CHIA usually reports this data just on a total aggregate population basis. We went in and we looked at the underlying data tables, and we're able to focus just on those residents of Massachusetts who reported that they had employer-sponsored health insurance. So these are stats just for the commercially insured or employer-sponsored health insurance. And you can see that 1 in 3 residents reported that their last visit to the emergency department or a family member's last visit to the emergency department was not for an emergency. And that was kind of classified as that they thought that a regular doctor could have been able to handle this in a different setting than the emergency department. And we can then follow up and ask, well, why did you go to the emergency department? And what we find is that there are some real perceived access challenges for many of these patients. Patients who are seeking care after hours, seeking care on weekends, seeking care through their primary care doctor, but may not be able to get an appointment. And so as we think about what are some potential solutions, how do we expand access to these patients and give them different access points for care when they need it to avoid having to go to an emergency department. This next slide looks at this broken down. Again, this is the survey data of employer-sponsored insurance residents. Looking on the left-hand side based on their health status, and on the right-hand side based on their income. And so just to orient you here, if you look at the far left, of those people who report that they're in excellent, very good, or good health, 32% of those individuals still reported that their last emergency department visit was for a non-emergency. And while you can see some variation on the right-hand slide in terms of their reported income levels, I think the important takeaway here is that this is not just a problem for individuals in poor health or individuals with low income. This spans the income levels, it spans health status. And so as we think about solutions and opportunities, this isn't just one patient population that we need to think about. The next slide here is looking at this through that different Billings algorithm way. And this is all emergency department visits. And when we categorize all of the visits through this methodology, we find that almost 40% of emergency department visits can be categorized as potentially avoidable, and broken down about half and half between those two subcategories that I talked about before. And here on this next slide, we look at that same rate by region of the Commonwealth. And again, it's kind of broken down by the two subcategories. The main takeaway and point here, even though that there is some variation, is that this is across the Commonwealth. There is not one region that necessarily stands out as being particularly high or particularly low. This is not an urban problem, a suburban problem, or a rural problem. This is a problem that spans the entire Commonwealth. And then additionally, when we look at this by age group of these individuals, again, we see that this problem spans age groups. We have a lot of visits that were categorized as potentially avoidable from children of members who are on commercial insurance, adults, and as well as seniors. So again, spanning ages, spanning geographies, spanning health status, and spanning income, this is an opportunity to drive savings in the Commonwealth. Just to give you a sense of what some of these conditions are, we can look into the data and see what some of the most frequent and common conditions, why are people showing up to the emergency department. So this slide just shows you some of the most frequent conditions for children who are categorized as potentially avoidable. And you can see some of the different clinical conditions here, again, broken out by needing some level of care or not. And then here again on this next slide, you can see this again for adults in terms of what are some of the conditions, these low acuity conditions that people are presenting in the emergency department for treatment. And finally, what we also know from the data is that the emergency department is a very expensive setting of care. If it's a highly specialized setting of care, but it does cost much more than other settings such as the primary care office, a retail clinic, or an urgent care center. So you can see here the average cost of an emergency department visit in Massachusetts was around $1,200. The average cost at a physician's office around $165, a retail clinic around $70, and urgent care centers around $170. And this isn't only just cost to the system, of course. Patients are paying an ever-increasing portion of their care, and you can see that reflected in the out-of-pocket costs, which are 5 times greater for patients who present in the emergency department compared to some of these other settings. So as a coalition moves forward, one of our strategic goals really is around ensuring that patients have those options when appropriate to go to those other settings of care, and when they need emergency care, that emergency care is there for them. So we think about this as a vision for right care for you. And what that means, the 4 key strategies that make up the right care for you is the right care in the right place, at the right price, at the right time. So these 4 right strategies also make up our hashtag for today's event. So if you're tweeting out for today, encourage you to tweet out with the hashtag Right Care for You, our vision for reducing avoidable department utilization. And as the coalition moves forward in making that vision a reality, we have a lot of different strategies that we're going to move forward on in 2019, including engaging employees with new information, maximizing our data assets and measurement as measured before, building a multi-stakeholder collaboration as reflected in this room today, and advocating for the types of policies that will increase access to care when patients need it. So with that as an introduction to today's event, I'm not going to waste any more time, and I'm going to turn it right over to our keynote speaker for today. We are so thrilled to have with us from St. Louis, Louise Probst. As a proud Midwesterner, I'm so happy to have another Midwesterner here today. She is the Executive Director of the St. Louis Business Health Coalition and the Midwest Health Initiative, and you're going to hear a lot more about those organizations and what they've been up to. She started her career as a critical care nurse and has her MBA from the University of Denver. We're so happy she's with us this morning in Massachusetts, so please join me in welcoming Louise.
Thank you very much, David, for that nice introduction. I have to say I'm an East Coast transplant to the Midwest. It's a great pleasure to be here in Boston. I can't tell you how pleased I was to get this invite. Throughout my career, whether it was as a critical care nurse or supporting employers working in health policy, I've often found the work that comes out of your state to be really strong, both clinically and in health policy. I mean, I think you're providing a lot of the nation's thought leadership, and you have. I've come to know things that come from your state as being bold and brilliant, and I would say that your employer coalition's framework looks to be both of those. And so really excited to be able to follow that, your work, and I know you'll have great success. I'm really pleased to see Barb here, Barb Rabson. We in the Midwest really look at what they do in terms of patient experience and engaging, and so we appreciate that work, and have certainly borrowed from the Health Policy Commission's work. Love to look at your data analytics, and we do some reporting as well. So it's really nice to be able to be here and share a little bit about what we've done, having been the beneficiary of so much of your work. I want to share our story, and I think I really have 3 goals. And find this slide. So my 3 goals are to introduce the St. Louis Area Business Health Coalition and the Midwest Health Initiative, and help you understand how the employers are trying to influence and nudge care delivery in our community. Share with you a little bit about why we chose emergency department use and why we chose a community multi-stakeholder collaborative to kind of approach that. And then finally talk about our challenges, learnings, and early results. And so I want to be able to do all those things. I have some fairly detailed slides, and in order to really just focus on the important issues, I won't be talking about all of them, but all of the information is there. So first, who's the St. Louis Area Business Health Coalition? We were founded by the region's leading employers in 1982, just celebrated our 36th year. We have many of our same founding members with us, and they started our organization because way back in 1982, these employers felt that healthcare costs were going up faster than anything else they purchased. When I look at some of the early minutes, they were concerned because they didn't think that the value or the quality of care was improving commensurate to what the costs were. And they really wanted an organization that could wear their hat as purchasers and help them bring their voice to the table. So that's what we do. And they also put in our founding bylaws that we would do reports about the hospital, and back then 80% of healthcare spending was at hospitals, cost and quality. And so we've been doing some of that reporting ever since. And we have in our bylaws as well that membership in the coalition is open to any employer that doesn't make its revenue financing or delivering healthcare. And so for the most part, you'll see here, people ask, who are your members? We're large, national and multinational service and manufacturing firms. We're utilities, gas and electric companies, we're school districts, we're universities. We are some smaller, more local organizations, but it's a pretty diverse group. Even in 1982, the benefit consultants wanted to get in, and our founding leaders decided that they should be sustaining members, because even the benefit consultants had an interest in the healthcare industry. So really have tried. I will say 2 years ago, our board opened healthcare HR partners, and that's because a lot of people that had been strong leaders in our organization had moved to some of these organizations and wanted to partner with us. And so if they have an HR department, and we're really working with HR people and other products and service people, a healthcare organization can be a human resource HR partner. So that's our membership. In 2010, our leaders were concerned with the level of transparency in our community, their ability to really look at data, and that they didn't have enough opportunity to work collaboratively with the healthcare providers in the community, and really work together with health plans and health systems and medical groups in a more structured way to improve the quality and affordability of care in our region. So they started the Midwest Health Initiative. We're what you call a Regional Healthcare Improvement Collaborative, or a RIC. We're members of the Network for Regional Healthcare Improvement, which is a national association of groups like ours around the country. And we collaborate and share information. So one of the things we did is put together an all-payer commercial claims data set, because we needed more granular information to really know what we were doing and where we were going. And so today we have about 1.6 million lives in that, commercially insured people from around the state. And then we have what we call a common table, but it's the place where all the stakeholders can come together, pick projects, and I've listed a couple that we've worked on in the past. Emergency department use has been something we've been focused on for about the last 2 years. I will say that our data is collected statewide, but our community collaboration is really just the St. Louis region. Kansas City and St. Louis and Cape Fear are really different communities, and it's hard, if you're just coming from one place. So we found that we've been encouraging a group to get started in Kansas City. We're really eager for them to get together and start to do some collaborations, so that we can learn from them and we can also compete with them and really challenge each other to drive further in terms of our improvements in healthcare value. So what are our foundational beliefs? Our role and our is to really bring together, as I said, those that pay, provide, and use healthcare services. But we vision our region to lead the nation in healthcare quality and affordability. So we have a long way to go. I think we're leading affordability, actually, for one of the lowest cost priced communities. Still, we think costs are high, but we have a ways to go in improving health and care quality. We believe that healthcare is everyone's responsibility. We've all created the situation that we're in. There's no one party that is totally responsible for this. In fact, employers might be held the most responsible. For too long, we cared so deeply about healthcare that we overpaid. And we said, whatever you produce, we will buy, and whatever you tell us the prices, we will pay for. And so we as purchasers have a lot of responsibility in the incentives that have been in that marketplace for the last 30 or 40 years, and we understand that. So we really think that we need to come together as a community and try to solve these issues, and that no one entity can do this alone. And so that's really important. I think it's also important to say that as this convener, we don't pay for healthcare. We don't have a couple of employees. We don't provide healthcare, and we don't organize networks or contract. And so we really can't do the work. And so as you're convening these groups, you have to realize with some humility that you're not going to be doing the work, others are, and just really try to build the support and the trust and the partnership that allows that work to get done. Let's see, flipping on, there's one other relief we have, and we think the regions that do the best job at this in improving the value of their healthcare will also lead in economic development and being a high quality place to work and live. And so we really think we need to get some competition going. I tell you, our employers want deeply for providers, physicians, to compete on their next, on their patient care. To think that each patient encounter is the most important thing that's going to happen to them in terms of maintaining and attracting their business. But we also think that we all need to compete as communities, and that's why we're thrilled that Kansas City's interested in getting together. They're stronger than we are in primary care, and I think that they can really challenge us in some important ways. I'd love it if you all sent us a letter asking us to compete with you on doing some things around emergency department. We compete on so many things regionally. Why couldn't we have some challenges and recognition and rewards for communities that came together and did the best job in improving quality and affordability? So hopefully you'll come back with a challenge. I'd like to leverage that in my community. So, okay. I'm not going to spend much time here. We use Kaiser Family Foundation to know how we compare. We have data on our own community, but we don't know how we compare to others. And we're number 10th in the nation for the number of ED visits per 1,000. And our costs are just as high as yours in relation to emergency department care versus others. We also found out, though, that there's a lot of opportunity across all the medical groups. So probably, as you know, when we took the time to go back and attribute these visits to individual primary care physicians and then roll them up by medical group, we could really look at the variation. When you look at averages, we can get lulled into complacency. Oh, they all look about the same. Maybe that's the right level. But when you roll it back to practice sites within those medical groups, you can kind of see the difference. So the green boxes are the averages, and then the circles at the bottom are the top performing physician practice in that group. And the top is the lowest performing group. And so you can see that across all the medical groups, there was an opportunity for improvement. And so we thought that this means it's a really good starting point for us and also for the medical groups. We also found, like you did, I think these 5 conditions, represent a very significant portion of our avoidable visits. Now, I will say that we weren't as bold as you were, and are. Maybe now we'll be bolder next time. But we used a definition of avoidable ED visits out of California Department of Health, and it's a very conservative definition. We told everyone when we went out, hey, listen, we want to give you the benefit of the doubt here. We're using a very conservative measure, and this is what we think. So our measure came down to something around 16%. But we felt like if we can start here and then move forward, that would be great. But the one thing is when you look at respiratory infections and earaches, these things should be able to be moved out of the emergency department. And so another indication that this was a good place to get started, that there was, we could have some success. We didn't know at first. We started to have conversations, and we were really pleased to find out that everyone thought this was a good idea. Emergency room doctors we talked to thought it was a good idea. Health plans thought it was a good idea. Employers liked it. Labor unions liked it. And so there was a lot of shared interest. I will tell you, in terms of the employer motivation, when we talk about improving the appropriateness of ED use, what we're really saying, AKA strengthening primary care. Employers care deeply about primary care. We want stronger primary care. Working on emergency rooms is one way that we can support and strengthen primary care. So that's what it really means to the employers. It also is an opportunity for the employers to better engage their patients or their employees in sharp and smarter spending. And it's a great opportunity to illustrate that and begin to have a conversation there. There's a couple things down at the bottom in blue that are more unique to providers. They have risk-sharing relationships, and while there aren't as many in the commercial space as we'd like, there are some quality bonuses, and they know that they'll do better today and tomorrow in their risk-sharing models if they can help people move out of emergency departments. And they also want to reduce leakage. So if you're a medical group and there's no guarantee when your folks your patients go to the emergency department that they're going to one that's owned by your hospital system. And so you could, one, get dinged because they're spending more money on your risk-sharing relationship, but they could also be spending that money at one of your competitors. And so they're really concerned about this issue of leakage. So back to the employer side of it. If anyone here has worked with employers, one of the things you hear So I can't do that because I could do that in Boston, but I can't do that in St. Louis, or I can't do that in Seattle. I have people all over the country. And so, all of us and most all major companies have people in every market. And it's hard for them to do different things. They want to treat their workforce equally. So the question for us with employers is, can like-minded employers or providers or health plans achieve a meaningful impact by aligning their actions towards a single focused common goal, even if they use different levers? And so I think it was really important for us to say, listen, you don't have to all do the same thing. We know that you're a labor union, you negotiate your copays, and we know you only have a $25 copay for emergency private visits. But could you get it up a little bit? Somebody else, you can do something different. So the idea is that employers or other organizations may not be able to do everything, but they can all do something. And so I think, not being so prescriptive, but giving people a menu in the way that they can work. Also, employers have a longer planning cycle, and so if you just show up, it might be 18 to 24 months before they can take action. So, but I think that you'll be pleased if you start to have those conversations. These will give you some detail about our aligned actions. Again, I'm not going to go through all of them, but it's a path very much that it sounds like you're taking. We've been at this a couple of years, but before we actually started the work group, we spent a lot of time getting our data ready so that we could really roll back to individual providers and organized medical groups and such to make our information more actionable. Then we really did some assessments of access. Where are people getting care and what's available in our communities? Had a lot of conversations with our providers as well as the employers. And so this is kind of what our aligned actions look like. The biggest thing, the action that we took, was making the ask and acknowledging primary care physicians. So the Business Health Coalition sent a letter to every primary care physician that had billed for services in 2 years in our community. And we thanked them for their work and their commitment as a primary care doctor. We let them know that the employer saw primary care as transformative to healthcare. We asked them to ask their patients. So we asked them to make that ask. We didn't ask them to extend their hours. We said, have a conversation with your patients when they come in. Ask them if they've been to the emergency room. And if they have, see if you can help them find an action plan so the next time they have a better solution. Please let your patients know what you would like them to do if they get a terrible headache or they have a urinary tract infection. And so we made that ask. Likewise, we went to the employers and did communications and lunch and learns and other things to ask the employees to engage with a primary care doctor, or at least to have a plan. Millennials might not have a primary care doctor, and I don't think baby boomers did either when they were the age of millennials today. But they can still have an action plan. Like, this is my network, and this is where I'm going to go if I have an emergent healthcare need. And so we had those kinds of conversations. A little bit of detail. Our actual work group time was not that extended. We spent about 10 months together convening. We had 6 meetings over those 10 months. And we did the major work with toolkits and the deliverables during that time. And then, of course, because we as a coalition don't actually do the work, we stopped the work groups with the idea that we would convene in 9 months and find out what kind of progress they had made. And I'm pleased to say we just had that meeting, and there was a lot of progress made, and I'm going to share a little bit of that in a minute. So, you never know. I know one of the challenges, you're wondering, are they going to come back? Are they really doing any of this work? Are they just coming to the meeting because the employers are there? By they, I mean the delivery system. And they want to be polite, but are they really doing some of this effort? And I think that it was good news. And so this is just an example of where to go for care that we worked on collectively as a community. I don't think any one entity is actually using this specifically, but they've all taken it back then and customized it as appropriate. This is where one of our challenges I'll talk about is it's hard to do this these days because everything is morphing. Urgent care is really, in some ways more like an extended primary care and then convenient care. So it's really hard to know what goes in the buckets except for kind of what goes in the red bucket when you really need to go to the emergency room. So what do early results look like? We are, in a couple of weeks, we'll be able to tell you what the emergency department utilization looks like for the first 6 months of 2018. But you can see the trend there, and that drop from 16 to 17 is about 5%, it's 4.8%. So we are seeing finally emergency department use decline. We were really worried when we saw it looking kind of flat and urgent care went up so steeply. We started out thinking that urgent care was just a new bucket, because we could see primary care visits were declining, and we could see that urgent care was going up pretty steeply, and it didn't seem to be taking a bite out of emergency room use. So it made us think that people were going to urgent care for things they might not have been getting care for. And as employers, we're always worried about these buckets, that like just sort of take a lot of money, and they're, put together to try to be a lower cost option, but sometimes they don't really reduce cost in ways that can be measured, but they add a new bucket of cost. So I think that might be too soon to make that conclusion, and we'll see how that goes in the future with the way that most provider systems now have embraced an urgent care and are using it in different ways. So what were some of our challenges? Well, when we first got started, we had all the medical groups from every major health system in St. Louis participating, but they were telling us that they weren't really sure what the overall systems and incentives were. Back then, we still had hospitals advertising emergency room waits, and we asked them to stop, and I'm pleased to say that we don't have any of those billboards any longer, that at least I see. But the health systems would say, if you look at our scorecards internally as a medical group, when we look at ED visits as a medical group, that's a red light. That's not a good thing. But as a health system, they really like emergency room visits from commercially insured patients. They don't want them from Medicare, but they like them for commercially insured. And so that was kind of a challenge. And they had one physician say, "What? I've been coming to meetings to reduce ED visits for commercial patients?" And so you have to realize, and one of the reasons that's in it for employers is we have watched the last couple of years all this cool stuff happening in Medicare Advantage, and providers really willing to tell us about it. But then when we say you do that for your commercially insured patients, they say no. And so one of our goals was to put the commercially insured patients on a news cycle. And we wanted to get our attention to providers and say, "Hey, we're out here too." And in honesty, some of them said, this is such a big change for us, and we're so early in it, and we're at risk, and we don't know that we're going to do well under these relationships. We need our fee-for-service commercially insured population to pick up the slack if we get into trouble. And, that just isn't okay over the long term for commercially insured people. So that's one of the challenges. The second was that reducing emergency department utilization became political. We didn't know when we started, and everyone said this is a great thing, that one of our major insurers was about to roll out a policy that denied coverage for emergency services in the emergency room, and you probably had some of that pushback in this community too. It became national, and so we found legislation in our state, in our legislature, that basically did a lot of things that caused the employers concern. So it sounded great. It was about surprise billing and other sorts of things, but in there were some regulations that suggested that you couldn't get full payment for multiple services on the same day. Insurers could no longer discount if you have 4 or 5 things done in one visit. You had to pay 100% of each. There were just a lot of other things that got put in this bill, and it meant that we had to divert our attention and talk about a lot of other sorts of things. That all worked out, and I think the health plan agreed to make their denials based on presenting symptoms, and they were doing it on the presenting symptoms and not the final diagnosis, and I think that's becoming the national standard. But it was just noise that made it a little bit harder in the beginning of our work. Overall, I don't think it had a big impact, other than we had hoped to standardize the definitions a little bit of what's in an emergency, what's the definition that you use to define avoidable emergency department use, and it was just a little too complicated to do that. Let's see, urgent care I've already mentioned. It's still very much in transition, but the urgent care, what you did in urgent care when we got started is very different than the way urgent care is working today. And then my personal disappointment, and maybe because I'm a nurse, is I really thought that the big benefit would be working on these care plans, these action plans, and that we could do this with physician input from all the different groups groups and come up with some standards and then take that out. Employers could use it to help their employees think about what that might be. And there wasn't much interest among the medical groups in doing that, and that was kind of disappointing. I thought about how cool it would be if you went to your primary care doctor and they said, hey, I know you have a problem with migraines or urinary tract infections, and here's what I want you to do. And so that didn't happen during our 10 months together. There just wasn't much of an appetite for it. But we did come to consensus that we should really encourage the medical groups to develop these. And I will say that that has been happening. So let me tell you what we learned, that this is really a great area for community focus. There are so many layers to this and so much opportunity. I will tell you that the diverse stakeholders really appreciate coming together. We had strong employer leadership. Someone from Boeing chaired our committee and was very actively involved, and I think that helped a lot. We found that this is not a one and done for sure. It's a journey. When we ask our providers at the union and our labor unions, other partners, hey, do you think we need to get together again? They told us really clearly this is a journey. We absolutely need to get together again. And so we will be continuing the group on this focus and sharing the information. The employer voice was very important and very much appreciated. We've heard that over and over. And the employer stuck with it and came to the work group meetings, and we really appreciate that. We have, surprisingly, one of the IPA groups took our work group. We kind of thought that toolkit, the work group output, might not be that useful. Like maybe we're writing something that everybody's already doing. And they came back at this last meeting and said, oh my goodness, we were so surprised. We went out to the actual practice sites and sat down with the managers in those practice sites, and guess what? They hadn't trained their office staff on what to do, and they weren't using any scripts. And so we found they basically reported that the toolkit was really, really helpful. You know, it's so important for an office manager to understand how important their role is and to share with them this problem of high healthcare costs for people when the emergency room impacts everybody, and that they are so critical. They said a lot of the office staff said they thought they were helping the physician out by suggesting people went to the emergency room. We found that telemedicine is finally really picking up. For years, people said, yeah, we have telemedicine, but nobody's using it. And now we're seeing the beginning of some growth in that area. And then my big question that I left this reunion wondering is, hey, are consumers finally having an impact? And I have to say, it's probably the payments, and CMS would probably, and Medicare Advantage, owe a lot of this too. It seems that providers are really redesigning care delivery to work better for patients and for the public, and that is really, really good news. And so eager to watch that transform and see if we can spread that across the entire health system. So lots of good news. Some of the specifics I wanted to share with you. So when I walked into the room for the reunion, there were some employers sitting there, and weren't they talking to each other about their rates per thousand and comparing that? And I have to say, 2 years ago, the employers had no idea. Some of them knew their emergency department use was high because their health plan had told them that, and that was their highest cost bucket or their fastest growing cost bucket. But if you said to them, well, what's your rate per thousand? They didn't have a clue. And if you asked them their avoidable rate, they didn't know. Until today, they're talking to each other about what their rate of avoidable is and what their overall rates are. So that's really cool. We're seeing more and more worksite clinics. We have a serious primary care shortage. You may also. We're pretty much a specialty-driven community, and so we're putting in worksite clinics and revisioning the worksite clinics that are out there. We find that PCPs are having the conversations that we heard about 2 different toolkits that have been developed in this last 10 months. One is for patients with COPD, and there's some rescue drugs and a worksheet that gives them orders what they're to do. And then as soon as they take and initiate that rescue kit, they call the office, whether it's a weekend or during the week, leave a message with the exchange or otherwise to say, I'm starting my rescue kit. And someone gets back to them and gets them in the office. And I have a mistake on my slide, that's UTIs. There's another group that have developed action plans for patients with recurring urinary tract infections. So we think that that is really great and that patients will appreciate that. We have 2 orthopedic practices that have added evening hours. We have a large primary care medical group that in each practice site, a nurse practitioner keeps office hours open from 8 to 10, and they tell all the patients in that practice, we have a walk-in clinic from 8 to 10, and that's very encouraging. We have another medical group that told us that they have logged patients' risk levels and flagged them with a red banner at the top so that when they call in and the receptionist looks, they know to stop the process, go get the doctor or the nurse and let them know that this patient is a high-risk patient is in need. And so we think that those are all really, really positive things. We want to think the system is transforming the way that it delivers care. And that's it. I just want to acknowledge that, again, we don't do the work, and so I want to acknowledge many of the people that did. Bruce Hanson from Boeing made a huge contribution. Our health plan partners that really, bring their data and their leadership. And, we had a small grant, very appreciative of that, from the Arnold Foundation and through the Pacific Business Group, the Purchaser Value Network, that really helped us do some of our early data work that we needed to get done.
Sure. We have time for a question. We have a microphone.
Thanks so much, Louise. I'm Barbara Repson from MHPP. So I'm so intrigued by this letter you sent out to the primary care docs. First of all, thanking them, which is so powerful. And secondly, suggesting they have conversations with their patients. What kind of feedback did you get back from the primary care docs after those conversations?
It was very positive. First, I'll say that oftentimes the medical groups tell us, don't send it to the primary care doctor, just send it to us and we'll get it out. This time they said, no, send this to each primary care doctor. So that was interesting. We got some really positive feedback from the primary care physicians that they really recognized the fact that they were being recognized by the employers. And so I think it was just very positive. We have the St. Louis Medical Society decide they want to be our partner in our next project, which is using the Millman Waste Calculator to deliver other low-value services. And I think maybe, it just helped us build that rapport that we're in this together as a community and that we really want to strengthen that primary care.
Good morning, everyone. My name is Rick Lord. I'm the president and CEO of Associated Industries in Massachusetts, and I'm very pleased to be co-chairing the Massachusetts Employer Health Coalition with Eileen. And on behalf of us, Louise, thank you for that great presentation. Thanks for joining us this morning. I think there's a lot we can learn from what you've done, so I'm sure we'll be in touch even after this morning, so thanks so much. So I'll ask the panelists to come forward and take a seat. We have a great, robust reactor panel, and we're going to talk about what's happening currently in Massachusetts and what is the potential for improvement. While the panelists are coming to the front, I do want to recognize a couple of other public officials who are here with us in the audience. Lauren Peters is the Undersecretary for the Executive Office of Health and Human Services. Lauren, thank you for being here. And Matt Vino is the first Deputy Commissioner of the Division of Insurance here in Massachusetts. So thank you, Matt. Thanks, Dave. So let me just briefly introduce the panelists. Starting to my immediate left, we have Lisa Calentra, Chief Administrative Officer for Chestnut Hill Realty. Next to Lisa is Bill Grant, Chief Financial Officer for Cummings Properties. Dr. Steve Strongwater, President and CEO of Atrius Health. And finally, Dr. Thomas Hawkins, Senior Medical Director for Population Health and Analytics for Blue Cross Blue Shield of Massachusetts. So we only have about a half an hour, so I'm going to ask the panelists to keep their answers succinct because we want to get some dialogue going between all four of you, as well as maybe get a couple of questions from the audience. Yeah. So I'm going to start with Lisa and Bill. If you could just share with us a little about the employer that you represent, because many in our audience may not know your organization, but share with us any experiences you've had in terms of employee engagement or employee education about healthcare in their utilization of the healthcare system, and maybe any challenges that you face in doing so. So, Lisa, do you want to kick it off?
Sure. You guys hear me? More closer? Is that better? Chestnut Hill Realty is a small property management company. We have about 230 employees. About 190 of those employees are actually in Massachusetts. I would say that our biggest challenge regarding employee engagement, truthfully, is that from a grassroots level, so Bill's the data guy, he's the financial guy. For those of us that are in smaller companies where we have firsthand touch to people, the benefit that we have on this type of thing is that we can talk directly to our employees on a regular basis about, hey, it's better for you to go to urgent care. There are actually a lot of really good practical reasons why it's better to go to urgent care besides this. I think for us, it's about the value proposition for the individual employee. Why is it better for them? Why do they have to be so involved in saving money for the health insurance companies or for the doctors or for whatever? So I think that's our biggest challenge, truthfully, is what's in it for them. I could go on, but I'm going to turn it over to Bill, so we're going to be succinct.
Great, thank you. Bill?
Good morning and thank you. Cummings Properties, we're located up in Woburn. We own and manage about 11 million square feet. So if you need space, I'm available afterwards. We have insure about 600 lives. We have been able, for the last 10 years, to be on the Tufts tiered program, for which we've been able to leverage our paid claims, which were about 75% credible, out of the tier 3 into tier 1, because there are a lot of very good community local facilities and providers. With that, I know there's a lot of people who don't believe wellness programs pay a big dividend. We're not in that camp. We believe with over an 85% participation, we've been able to leverage the knowledge that we obtain from a very simplistic wellness program. We ask people every other year to have a physical and report to a third party 5 matrix, which is the blood pressure, tobacco product, body weight mass, sugar levels, and cholesterol. We have found through that over the years that 4 of those we're way ahead of the national averages, but we're terrible with cholesterol. So we've subsequently engaged a nutritionist to work with our people and run various programs to help us address that issue. Our biggest challenge is getting timely data so that we can utilize, because we do have our people engaged, to find out what's next and welcome to work with the various insurance companies, specifically Tufts and others, to be able to get that information sooner.
Great, thank you. And Bill and Lisa, I have other questions for you, but let's go to Steve for a minute. You head up the state's largest physician practice. Steve, what do you see as your role or your organization's role in this initiative, this employer-led initiative to reduce avoidable ED use?
First, I want to compliment you all for activating around this issue. It's pretty remarkable, and I would start by saying that the center of this initiative should be about what's best for patients, what's best for individuals. So to echo Bill, and I have to compliment the CFO of a company actually knows about these medical conditions. I really just want to applaud you. So well done. On our side, our principal role, and we have amongst the lowest ED use in the Commonwealth, has been to provide real-time access. That is on the phone, through our patient portal, through direct contact, immediate at night and off hours with a nurse practitioner. So it's really all about access, capacity, and sufficient primary care. And I would say that as we talk about, and I love Louise's story and emphasis about primary care, The reason we do not have enough primary care providers is they haven't been well funded. And so people are directed into specialties where they get more money and they can then pay off their loans and debts. And we're seeing this extraordinary shift to advanced practitioners in addition to primary care physicians providing real-time access. And I would say that part of the issue with telehealth and the reason that it hasn't taken more to hold, and we are starting to use it ourselves, is that the national telehealth providers are not connected to the patient's electronic medical record. And really, what needs to happen is they need to be in a system of care where they can directly access their electronic medical records and be supported and follow up in post-encounter, post-visit. So it's providing immediate access. It's activating patients, much as I think Bill is describing, through the employer channel. And then it's having sufficient capacity to meet the needs at the time that they show up. So we've been very fortunate and very successful, I would say, by virtue of having a telecom program where after hours you can directly access our nurse practitioners, and almost uniformly we can get you in the following morning to get seen without you having to go to an emergency room.
Great. Thank you, Steve, for sharing that with us.
Wait, can I add one other thing? I apologize,
You
I'm
can.
not being short.
That's okay.
One of the things that we're seeing is a drift towards fee-for-service reimbursement and away from full capitation. That is not helpful. It isn't helpful for people who make investments in infrastructure to create the kind of access that I just described. It may be easier to administer that on an employer basis, but in the context of total medical expense management, it isn't very helpful.
Well, great lead-in for Tom. So, Tom, Blue Cross Blue Shield is actually a leader in moving away from fee-for-service. Can you talk a little about the motivation for that and where you folks are, addressing Steve's concern about shifting backwards?
Well, we share that concern. We have spent the last 10 years working on ACO contracts.
We didn't plan this.
Through our alternative quality contract here in Massachusetts and now nationally with the Blues in the our ACO global contracts across the country. We have seen a reduction in non-emergent emergency room use through leaders like especially Atrius, who has a very long history of managed care and going back and having open hours and urgent care centers and have really been leaders in that area. But in addition to what we've seen from the alternative quality contracts in this state, which is really important, we hear anecdotal stories from people that their doctor opened up after hours slots, that they have weekend slots that just wasn't happening for many of the larger groups prior to about 10 years ago. But in addition, we had to do some learning. We spent a lot of time learning about social determinants of health. We read all the literature going back 10 years from the Health Policy Commission and the predecessors about why people use the emergency room. The fact that it's not all the uninsured, it's not all the people that are struggling. It's plenty of people with doctors, with insurance, who have this behavior of going to the emergency room. We also learned that it's highly determined by socioeconomic factors, education, income, the ability to leave and work, the ability to have transportation. These were all really important factors. So we began to work with a whole series of employers, and a couple of things that we've done over time is that we've had a 7x24 nurse line, and I know that Atrius has had a nurse call line for a long time. That we can use nationally, which has helped a little bit, but it takes constant marketing and educational. And the minute we really work at it with an employer, and then 6 months later, if you don't keep communicating, it drops right back off again. But slowly that's been improving. Our union funds began publishing locations of urgent care facilities and really started working and getting the stewards, union stewards, to directly speak to people. And in fact, our most successful employers so far really increased their urgent care use and did see that slight decline in ER use, as was mentioned by our speaker. By in-depth, down in the weeds, the supervisors at this employer had to sit down with groups of employees one by one to point out where local urgent care facilities were. They had to tell about their own experience going there. You can't just tell people to go to a registry or list somewhere or send them emails and expect that they're going to make the shift. This requires really in-depth work with personal examples in our experience. And then finally, we have not yet seen the telemedicine urgent care take off. The behavioral health seems to be moving up faster than urgent care visits, but we hope that will work. And we are working with some large national players. We have a big data mapping tool now for the whole country, and we're able to look at transportation barriers, local urgent care, ER plus lines. You have to understand all this on a national basis to know where you have to apply your impact. So,
Steve?
I would just want to emphasize that how providers are paid impacts how they design their delivery system. And if we continue to pay exactly as we have paid, not a lot will change. The other thing I would offer is on a population health basis that people use emergency rooms for different reasons. There is certainly the unavoidable acute injuries for which there's no way to prevent that. But then for chronic conditions, recurring problems, you can use data analytics to identify those individuals. And as I think we heard in St. Louis from Louise, that you can have rescue kits and rescue plans. So the kinds of interventions that you design can be aided by analytics and then can be very targeted and tailored. The infrequent, unpredictable accident is going to wind up in the emergency room. You should give up on that. It's all the other stuff, the low risk stuff that you should focus on.
So Steve, you mentioned the importance of how we pay providers in terms of the types of behavior that we see. I'd like to ask you all about plan design for consumers and financial incentives and whether those make a difference to encourage, good behaviors or discourage bad behaviors. And I don't know, Lisa or Bill, you want to talk about that?
Bill referenced wellness programs. I completely actually agree that wellness is actually a very important part of this because I do believe that there's a business value to incenting good behavior rather than punishing bad behavior. So the sicker you get, the more money you spend, the more it costs everybody else, right? And again, I'm talking about this is the employee experience and they are our consumers. So I do believe that there's a benefit to wellness. There is a benefit to, you guys talked about marketing. That's some of those real challenges as well, right? Is keeping this stuff in front of people.
And
I'm very passionate about wellness.
yeah, no, absolutely. So, Lisa, have you used plan design and financial incentives to encourage different behaviors among your employees?
Currently, we have a wellness incentive. We do not currently use incentives through our plan design to incent our employees. I don't know if that's something that you guys have utilized, Bill. We're constantly tweaking our plan to make it affordable.
Everybody got that message, I guess.
Our plan design, again, is through the tier network. So if you're in a tier 1, there's no deductibles. And if you're in a tier 3, I think it's a couple $1,000. But a couple things when it comes to plan design that I think works against the consumer. It's my understanding many of the providers have 3-year contracts, whereas the consumer, we end up with a 1-year contract. And when they're trying to project rates, like in our case, I know they worked on our numbers probably July of August of summer of 18 for fees that would be paid as late as March of 2020. So when they're trying to look into the crystal ball and see where things are going to be that far out, I find that extremely challenging. The other part that would be, in my opinion, a big benefit is a very simplistic EOB. There's been talk of that in the past, but I still hear when the people do go to the emergency room, well, it only costs $150. Well, we all know not really. And if something could be conveyed back to them, again, either through them or again through the company, so where we do have engagement, we can leverage that information.
I also just make and I'm not this is not new or exciting information for anybody here. But when we talk about plan design and we talk about specifically high deductible health plans, Steve, you mentioned that at some level we're mostly trying to talk about health here. That I think that defeats the purpose a lot of times. I know a lot of our employees, I know a lot of, if anybody here is offering a high deductible health plan, you have employees who are not going to the doctor because they can't afford it. And so I think for the actual employee, for the actual consumer, when you drill it down, that's what we're getting down to. We're talking about really, big picture strategic things here, but when you drill it down to the employee, that's their reality. They're paying $100 or $200 a week for their health insurance, and then they're paying an additional $2,000. So when you talk about plan design, I know that's not what we're here to talk about today, but to your point about, if we're actually worried about the health of people, that it's a concern. It's a concern I know I have as an employer for my employees, and I would guess many people in the room do as well.
Steve, you want to react to that?
Well, I think that high deductible health plans could be creating access issues. I would say that in value-based intelligent plan design, you could fund up all the prevention for free and kind of overcome that as a hurdle, and also be in a full cap arrangement where over time there'll be much more emphasis and intervention on prevention and education. At least in our practice, that's how we would approach it. For those who don't have that, I would hope you're offering flu shots on site, and that's a great opportunity to educate people about use the urgent care centers and not emergency rooms, because you're going to see and touch every person who might be at risk for the use of them. So
That's where your wellness program can help. That's where, that's absolutely which is why wellness is so great.
When we plotted out co-pays by non-emergency room use, there's a huge distribution between different employers. It has a lot to do, as I mentioned before, about the employees that are there, the education level, the income, the ability, all these things. But when you really look at the average, yes, over time when you increase the copay, there is a slight decline in the non-emergent emergency room use on average. But when you then look at that variation, which was mentioned earlier, it looks like a sawtooth. As the copay goes up, it's not a straight line average. And so there's wide variation between employers, and there's wide variation within large employers. The distribution centers with one set of employees versus corporate headquarters here versus retail stores versus manufacturing within one company have wide variation for a whole variety of reasons we've discussed. And you have to understand those and address those differently.
Tom, why don't you keep the mic? I have a question for you to answer something Bill raised, which is the EOB, the explanation of benefits, the statement that employees receive, and could they be designed better to help educate and engage employees about the real cost?
Sure, we worked really hard to redesign ours. Of course, it is a state regulation that they have to be in a certain format in a certain way, but within that, we've worked really hard to try to improve them. There's always room for improvement, and we'd be happy to take suggestions any way possible, but they still have to pass the state regulatory approach.
Question for the employers, and it goes to something Louise brought up when they had their reunion recently. The employers in the room were talking about their rates of emergency room use and non-emergent use. A question to you, do you know what your rate of emergency room use is? Do you get that information from your insurers?
Not really.
So as part of this initiative, maybe we could work with the insurance companies to make sure that they're providing you that information on a regular basis. I think that would be an important step for us to, obviously, to measure progress. Steve, do you want to comment?
We do report it each year and on a more frequent basis as needed to all of our customers. I think it's something they can focus on and work on. I think, as was mentioned earlier, it's not the largest cost in the whole spectrum, but it is something everybody can work on and talk about. And so I think it makes a great focus.
I actually do know what the per thousand use of our patients is.
Mhm.
I don't know if I should say publicly. I'm going to get my sense back up to 20 per thousand. Yeah. I don't know if that's high or low. That's commercial. Yeah. So we work every day at this, and there's an opportunity to collaborate with providers. The one thing I just want to emphasize, and we learned this from some researchers here in Massachusetts, is that price drives the cost. It might seem apparent, but what people charge, either in the emergency room for what is a true emergency room visit or what is a but needed visit matters. So the way the plans pay, which is what Anthem has tried to go after, does matter. And it is location where people get their care, but there might be other price strategies to consider, as well as working collaboratively with providers to try to figure out how to get people to the right site of care.
Bill and Lisa, it sounds like you are kind of in the forefront of employers in terms of engaging your workforce and encouraging, appropriate use of the healthcare system. I wonder if you could talk to us about, do you ever find any pushback or challenges or things that haven't worked that you could share with the audience?
He wants extra time today.
No, overall, no real pushback. Took a while on the wellness, again, to get up to 85%. And that last 15% is still a mystery. We do offer a wellness discount for a family plan. It's about $60 a week, so it's real money. But why that other 15% does not participate, there's some questions. It's just a question of big brother sort of watching and just not feeling comfortable that we really don't know what's going on in their lives, and candidly, we don't have any desire to know what's going on in their lives.
I would agree with Bill. I think that the bigger pushback is on the wellness. And we actually have a similar business model. So we have a small company spread out over many locations. So trying to create, that collective spirit of this is good for you can sometimes be challenging. And we get that. We get the big brother. We run a Know Your Numbers similar to what you do every year. We run a Know Your Numbers campaign on the prevention side because it's absolutely critical. We do want things like that, but again, we do get a lot of pushback from people who seem to think
It's not your role. This is your role.
or that they really think that, I don't know, we have gnomes at the corporate office who are secretly keeping all of their information. So I would agree that's a big issue.
Great. I am looking at my watch, and I'm going to open it up to a couple of questions from the audience. And there is a mic out there, so if you could just raise your hand if you have a question for the panel. No questions? Right here. Here's a question. Carol Allen, former commissioner of the Health Policy Commission. Glad to see you, Carol. There you go.
Thank you. So I'm wondering I'm not even going to go to the question of whether insurance should be provided through employers at all. But
Thank
Okay.
Are you sure? We could sit here all day if you'd like.
But to just build on on promoting primary care, I'm a pediatrician. I'm a big fan of medical home and primary care. First of all, it's nice to send thank you notes to primary care physicians. I think it's even more important to send them extra money to put in the systems that allow them to take care of patients so they don't have to go to the emergency room. So that would be one suggestion. And then for employers, are there other ways you can make it easier for your employees to go to primary care. So for example, giving them time off from work to go to a checkup or take their child to a checkup, could you consider something like that? You know, paying primary care providers to provide telehealth to their patients so they don't have to take so much time off to go to the doctor, things of that nature, sort of more creative solutions to make sure that people have access to preventive care and don't, and at the time that works for them and in the situation that works for them, as David pointed out, right place and all that stuff. You know, just what other kinds of solutions have you tried?
You actually make an excellent point, and one of the benefits to working for a small employer is I have someone who's highly engaged in that. So we do, as part of our renewal every year when we do our benefit meetings, we talk to people, believe it or not, about the emergency room versus urgent care. We've been doing that for years. But instead of talking about, here's how you can help the system, we talk to them about the time, right? The time and the cost and everything else. It's actually a much more efficient process. And as far, we also talk a lot. We train our supervisors, you know, again, down at the grassroots level, that this is very important. Getting healthcare is very important. We incent people to go every year to get their physicals, to get their families' physicals. We just expanded that 2 years ago to include the spouses as well. So we make sure that we're trying to do that. That's again the benefit of working for a small employer. It's a clear thing. Healthy employees are happier employees. It's not a mystery.
Yeah, overall, we're very, very similar. Geographically, we're located in a small area, so people can make their own appointments, and they all have various requirements for their job, but they're not by any means locked into not being able to take time off during the day or emergencies, and that whole professional balance of work, family life is an ongoing challenge, and we try to promote people to go do what they have to do when they need to do it.
Great. One more question over here.
Good morning, Scott Borman from Mass Bankers Association. From my background in human resources, I think I found that employees were afraid if we have the knowledge of their health that we would prevent their access to health care more than just us knowing the information. They were afraid that they would lose their coverage if they found out too much about their health. And one of the things this morning that I was surprised about, I haven't heard the ROI argument. And my background in human resources has been in healthcare for a good chunk of my career. So I've been involved in wellness for many, many years. And in the beginning, we kept hearing about, you know, soon we'll learn what the ROI will be. You know, we just need a couple more years of experience. And then it never really panned out. But what I find now is the know your numbers concept behind wellness and the biometrics and helping employees understand the status of their current health, I think has really helped them to get the care that they need when they need it. And I think there really is a return that we're seeing now as a result of claims that we're not seeing. And I wonder what you guys think about ROI.
Anyone want to comment on that?
I think it's there, but how I exactly would calculate or recalculate, I honestly don't know. But it is, I agree with you. I think it finds its ways into a number of other areas. There's some scary statistics out there. An injured employee can take upwards of 25% more time before they come back to work. They could, you know, injure their coworkers, and it affects their family life. So exactly what the calculation would be, I don't know, but I think it's something that people do, I think, appreciate and realize.
The ROI on this particular topic of urgent care versus non-emergent emergency room use is a little tricky at the moment because, as was mentioned by our speaker, it's not a one-to-one increase in urgent care and a decrease in ER visits. We're actually seeing, in some cases, both going up or stay flat. And so that whole issue is still not perfectly straightened out. Given a $1,200 emergency room for a sore throat compared to an urgent care, $170, it certainly makes a lot, or physician visit. It certainly makes sense on a one-to-one basis, but it's not quite playing out exactly that way. So we need to be sure that we're not just adding more visits that should have been at the physician's office.
I just want to mention one other thing about the wellness ROI, because in a small group, that's other pushback that, believe it or not, we received, because I know this year we received a very double-digit large increase in our insurance, because as a small group, we're about 70% credible, and we had a couple of people get really, really sick, badly sick. And so we have people who are highly engaged in wellness and they're paying, $20 more a week for their health insurance. Sometimes that can be a challenge for us as well. But
Great.
that also makes the ROI difficult. So we have a lot of people, you know why? Because all those people that got their numbers checked, they know their numbers now, and they went to the doctor. And I lost someone very close to me who was not doing this, so I'm passionate about it with my employees. You don't know who you saved, right? You don't know who finally went to the doctor with a dangerously high blood pressure, who got their life together. You don't know.
I'm sure we could go on, but I'm mindful of the time. So I really want to thank Lisa, Bill, Steve, Tom. Join me in giving them a hand. Great job. We look forward to all of you being engaged in this initiative going forward. And like Eileen, I do want to thank the employer members of the coalition, our strategic partners, and especially the Health Policy Commission for helping us staff this important initiative. And with that, let me turn it back over to David Sells. Yes.
All right, well, thank you again to the panel. And as we close out, just a lot of great themes here today. This is a journey, as Louise said, and we're excited to be on this journey with everyone in this room. So please make a connection with us. There are contact informations in your folders. And also, as I said at the beginning, this really is a coalition of action. And so in your folders, I do want to highlight that we have already prepared a number of sample resources for employees and for your use, including information about building awareness and social posts, things that you can put into your newsletters. As was mentioned earlier, a My Care, My Options worksheet that can be filled out with different types of where your nearest urgent care center is, where your nearest retail clinic is. Again, having this information available to you, not necessarily when you prepare it before you need it, so you have that information available. And then finally, we do have some posters around explaining some of the differences between urgent care and emergency department use and when you may want to consider different settings. These are sample resources for your use. We're interested in your feedback on them, and also willing to work with your organizations to customize some of these resources specifically for your organization. So please reach out to us. And there is, as similar to St. Louis, going to be a full toolkit that's going to be prepared as part of the coalition's work moving into 2019. Similarly with St. Louis, we do plan to have a number of work groups. We're not waiting on the work groups to begin this work, but want to have these work groups meeting concurrently with the coalition. So we'll have a strategic advisory council, a data and measurement work group, and a communications work group. If you're interested in participating in these work groups, again, please let us know. And finally, we're going to be going around and meeting regionally with different chambers of commerce and business organizations to get the word out in 2019. So please use some of these materials, provide us feedback, and be connected with this coalition as it moves forward. And so on behalf of the co-chairs of the coalition, thank you again, and have a wonderful holiday season. Good day.
Thank you.
Because I was subtly saying it. They telling me about
Absolutely fine. That's what I do. I